Hello everyone, and welcome to this case-based discussion aimed primarily at our third-year surgical clerkship students. However, this could be applicable to anyone that's on a surgery rotation or residency, where we're going to talk about the biliary tract and a little more. Hope to go through some cases that are very relevant to anybody in surgical practice to show you how ultrasound can help shorten the translation to history, physical, and diagnosis, and solve problems with you at the bedside, making your practice more efficient. For our objectives, we're going to primarily focus on patients that present with abdominal pain or swelling or maybe different swollen areas in the abdomen or groin. They may also present with vomiting, elevated liver enzymes, or maybe undifferentiated sepsis. And here's a couple of quick cases we'll look at, and then we'll come back to these after we review some of the findings. So this first one, this is a 64-year-old female who presents with upper abdominal pain and vomiting. This next case is a 42-year-old female who presents with upper abdominal pain, nausea. This third case here is a 37-year-old male who presents with right upper quadrant pain that is worse after eating. And our last case is a 22-year-old male who's got inguinal swelling and pain. So take a look at those, and we're going to review some of the findings and what to look for and how to look, and then we're going to come back and regroup on these cases. Just first, hit on a couple of just quick reminders about how to do specifically the biliary tract exam first. Most of the time we prefer to use the curvilinear transducer. However, if that's not available or we don't have a transducer with that, we don't have a machine that has that capability, then a phased array probe in an abdominal setting could work as well. A couple of tips, especially when trying to image the gallbladder: a deep breath pushes the gallbladder out from under the rib cage, so that can often help you visualize the gallbladder a little bit better. Sometimes having the patient roll into the left lateral decubitus position can be helpful as well. And I want to point out that sometimes placing the probe in several different positions may be necessary to help you, one, identify and then fully image the gallbladder. So my first place that I usually attempt is in the right subcostal region in the midclavicular line, and I usually like to start with a longitudinal view. Sometimes you may have to go above the costal margin in that same midclavicular line, so that's kind of my second choice. And sometimes you need to image the gallbladder from the mid-axillary line. Sometimes you even go up or down, anterior, somewhere in that axillary line, anterior, mid, or posterior, identifying the kidney and then shooting the beam towards the ceiling or anteriorly on the patient from there. And again, just kind of showing how I like to start this. I like to start in the midclavicular subcostal region, and if I find what I'm looking for, then always look in a sagittal, transverse, and oblique views. If that's difficult, then I may go above the costal margin in the midclavicular line, and then lastly, I may try from the patient's side, basically somewhere in the mid, anterior, or posterior axillary line, and then lastly, I may roll the patient into the left lateral decubitus position. Almost always, the full inhale is going to improve your images and give you a clearer, better defined image of the gallbladder. A couple of things: just make sure you recognize landmarks, know what liver tissue looks like. Always examine from the fundus all the way to the neck of the gallbladder. If you miss a little piece, sometimes you can get fooled by a fold and you think you've seen the whole thing, and then image it all the way towards the portal vein. So from the portal vein up through the neck into the fundus of the gallbladder, image the entire thing. If you miss one little piece, that's going to be the piece that has the stone that you didn't see. So always be thorough. Just to help you recognize some of the landmarks, we should see liver mostly all around the gallbladder, and part of this depends on the angle of which you obtain the image. And then you see the gallbladder. If it's normal, it's going to be a fluid-filled structure, and look for the portal vein, which you'll notice some little other tiny tubular structures around that. That's the bile duct and the hepatic artery running nearby. So these are all landmarks to help you make sure you're in the right neighborhood. And here's just a little video clip showing it kind of in real time. So we see here, this gallbladder has a little fold in it, so if you weren't careful, you could miss imaging the entire gallbladder. We see the kidney come into view, and then we see that portal vein, and I'll kind of slow this down. So here's the portal vein. We see these other little tubular structures nearby, and we kind of get it into a long axis view here. So portal vein, and we want to image the gallbladder from portal vein through the neck all the way up to the fundus, and we want to see the fundus kind of fully disappear to make sure we've imaged the entire gallbladder. Here are a few more examples. These are just some normals. Again, pointing out the landmarks. You see the liver tissue, we see the gallbladder. We want to image it from the fundus all the way down to the neck, and then here we see the portal vein. And remember, if you're looking for the bile duct, just find the portal vein and you know you'll be in the right neighborhood. The next example here, we see this gallbladder. This is a pretty easy one. Fundus down to the neck, and then we see the portal vein down towards the neck look as we fan through and examine that gallbladder in its entirety. The gallbladder can be quite variable, and it can have some slightly variable appearances. It can have folds. Sometimes it can be very contracted and be a little more difficult to identify. We look for the portal vein, look for the liver tissue, and that can help you make sure you're in the right spot. And when it's contracted, it'll kind of artificially make the wall look thicker than it really is. That's usually just a normal variation of a contracted gallbladder. There it is highlighted, and sometimes you can see these little edge shadows on the edge of the gallbladder, which you can see around many roundish fluid-filled structures. Here's kind of a moving clip, real example, but we see if we can recognize our landmarks, liver tissue, diaphragms all the way back here even. We see the portal vein here. We can kind of follow that main lobar fissure, and then we see the gallbladder sitting there with a contracted wall, but it's not truly inflammatory. That's not an inflammatory finding. That's just a manifestation of the contraction of the gallbladder wall. And then recognizing what abnormals can look like, and these can be also, again, quite variable, and these are some more subtle findings, but I want you to notice here, if we follow the curvature of this gallbladder, you see it's kind of nice, smooth, and you see something breaks up that smoothness, and this is a bunch of fine, tiny little stones. We can even see the shadow coming down from here. So these are some fairly subtle stones, but they do go all the way down to the neck, so these could have some clinical relevance. Here in this transverse view, we see the gallbladder here, the black fluid-filled structure, and we see kind of three little stones and these subtle little shadows coming down from this gallbladder. So pay attention to kind of a smooth posterior or dependent wall, and if it loses smoothness or it looks rough, then get a closer eye on that. That may be a sign of some stones. And then this example, we notice, we see this gallbladder, it looks a little bit contracted, but then we see this wall kind of looks like it's poorly defined, and it looks almost like the wall just kind of gradually fades into the liver, and that's because this wall is thickened and inflamed. So this is gallbladder wall edema, and that's one example of what that can look like. We'll look at some other examples here as well. Here are some more pretty striking abnormals. So if the gallbladder is completely filled with stones, where the stones go all the way up to the wall, then it can be a little harder to recognize. We may just see, we're in somewhere in the liver, and we see maybe there's a little edge of where the gallbladder wall is. We see this kind of bright white edge with a big shadow. This is called the West sign. So wall, echo, shadow. This is what a gallbladder can look like when it's just completely filled with stones. Similar example here in a transverse orientation. The gallbladder wall sits up here. There's not much bile evident because the gallbladder is filled with stones all the way up to the edge of the wall. So here's the echogenic stones with their deep dark shadow coming down, but we still, using other landmarks, can recognize we're in the right spot. And in this example here, we see the left lobe of the liver. We see the gallbladder, but you see how the fluid is not really the normal pure looking black that we would typically see. It's a little more gray, has a little bit of different echogenicity within it. So this is a gallbladder that's filled with sludge. This is all gray sludge. We see multiple stones up towards the fundus. So here are some stones with shadows. Here's a large stone at the gallbladder neck with a big deep shadow. Always want to be careful about examining the neck. The stones in the neck tend to be more symptomatic, so take a look for those. We also notice here this gallbladder wall. See how it's poorly defined and a little bit thickened. So this is a gallbladder wall with edema. So this is an inflammatory looking gallbladder with lots of abnormal findings. A couple more examples of sludge where we see this gray material sitting in the gallbladder, but one thing you'll notice is that sludge doesn't shadow. See how there's no shadows coming down from this sludge? And the gallbladder wall here otherwise looks pretty well defined, thin and crisp, so that's, even though there's sludge here, this is a non-inflamed looking gallbladder. In this example here, we see this gray dependent sludge. We don't see shadowing from it, although there does appear to be a stone up here in this gallbladder fundus with a deep dark shadow. The wall is a little poorly defined here. Not sure if that's just a bad slice. You definitely want to look through there and fan through that a little bit more to see if that really looks like a thickened wall in that gallbladder or not. And here, just, we saw a few examples already, but here's some more examples of pretty profound gallbladder wall thickening. You can see this wall is poorly defined. It almost has like layers, like an onion. When you see this multi-layered thickened wall around the gallbladder, that's an inflamed gallbladder. There's an inflammatory process going on. In this longitudinal view, just point out liver, portal vein. Here's this gallbladder. I don't see stones or anything in it, but we definitely see a thickened, kind of layered, irregular looking wall. We even see a little bit of pericholecystic fluid here, kind of between the gallbladder and the liver. So this has definitely some inflammatory findings. Some other abnormal findings to take note of. Here we're looking in the liver, and in this case we're talking about the bile ducts. This is an example of intrahepatic biliary duct dilation. When you see the ducts prominently running with the portal venous branches, and they're large enough that they're visible within the liver, then those are abnormal. In this example here, we've identified the main portal vein kind of right in the middle of the liver. You see liver on either side of it, and then we see the dilated bile duct here running with the portal vein. And the rough number to remember is about 6 millimeters. We measure this from inner wall to inner wall. Don't ask me why it's inner wall to inner wall. That's just how it's been standardized. Important to note that it is normal for it to be larger after someone has had a cholecystectomy, and it does get a little larger as you age. So we usually have a rule of thumb where you get a millimeter for every decade over 60. So if you're 70 years old, it could be 7 millimeters. If you're 80 years old, it can be 8 millimeters. So there is some variation for some of those different clinical scenarios. A few more examples of dilated bile ducts. We've identified the portal vein. If the bile duct is the same size as the portal vein, it's probably abnormal. This is kind of called the double barrel sign. Once again here, we've identified the portal vein kind of central into the liver, and we see the common bile duct. Again, even just your eyeballs tell you that that's probably abnormal, although you definitely want to measure it and consider, is this appropriate for their age or if they've had a cholecystectomy. So now that you know how to find the normal gallbladder, what it should look like, what are the normal variations, and what some of the abnormalities you may run across may look like, let's talk about how to integrate some of these findings clinically. Now, most commonly, you're going to have patients, again, presenting with things like abdominal pain, vomiting, maybe they're jaundiced, or maybe they're just febrile and they're a little out of it and they can't give you a good history, but you're worried that biliary tract pathology may be part of the problem. So you identify it, you're asking yourself, do you see some of the typical abnormalities like stones or sludge? Is it tender? When you have that probe right over the gallbladder and that reproduces tenderness, that's what's known as a sonographic Murphy sign. Is the wall thickened? Is it ill-defined? Does it have any of that layering we showed you some examples of? Is there pericholecystic fluid, which may be an inflammatory finding? And is the common bile duct dilated or not? So these are the findings to look for. Do you see these findings? Yes or no? Here's kind of a rough little algorithm of how to think about how to use this. So you have a patient where, cholecystitis or biliary tract disease is on your differential diagnosis. Right along with your history and physical, we've said this all along, you perform your history and physical and just incorporate point-of-care ultrasound right along at the same time as your history and physical. If it's completely normal, their gallbladder looks normal, the wall's thin, there's no fluid around it, there's no stones, there's no anything, then it's probably not cholecystitis. Now, could it be some chronic biliary dysfunction? It's possible, but that's probably not their acute problem. If you see stones only, but you don't see any other inflammatory findings, like it's not super tender, you don't see wall thickening or pericholecystic fluid, then you have to put some of the other information together with that. So what are their liver enzymes? What's their bili look like? Then maybe they need an outpatient surgery referral, or maybe these are just incidental. Remember, patients can have abdominal pain for lots of other reasons and have a completely asymptomatic gallstones. So this is where you have to be a clinician, you have to be a physician and incorporate all the data from your history, your physical, your point-of-care ultrasound, and any other data you may have, lab tests or other things. If they have stones and they've got abnormal liver enzymes or bilirubin, or maybe they've got an elevated lipase, then that is starting to sound like maybe this is a patient with cholecystitis and maybe even gallstone pancreatitis or something like that. Maybe this patient needs admission, a surgical evaluation, and maybe further workup, or maybe just start treatment and start planning on one of the next steps. And if they've got 2 or more signs, so they've got stones, they're tender, the history and exam fit, and you see maybe stones and wall thickening, then again, this is starting to add up to this is probably cholecystitis, and you should consider surgical evaluation, admission, and further treatment. So again, just want you to have a rough outline of how to think about this, but as always, point-of-care ultrasound is a tool that gives you information. You put that information together with all the other information you have about your patient to help you guide and make decisions. So we're going to go back to our cases like we talked about. So this was the case of the 64-year-old female who had upper abdominal pain and vomiting. And we can see here, this is an ugly, nasty gallbladder. We see, so here we're kind of slicing through the wall and we just see there's a lot of irregularity and different shades of gray. But as we kind of get the gallbladder in view, again, we can see the wall is thickened and irregular. It's got some of that layering. So this is an inflammatory finding in itself. And we see this big gallstone here at the neck with this big, deep shadow in a patient who has kind of the right symptoms and the right presentation. This patient likely has cholecystitis and warrants probably admission and surgical evaluation to consider cholecystectomy. And I'm not going to get into the timing and when you take the gallbladder out because there's a little bit of interpretation in that and a little bit of personal preference. And some of that's patient-centered depending on is the patient chronically very ill or not that ill. So a lot to think about there. So again, this patient shows up with these symptoms. You incorporate point-of-care ultrasound with your history and physical. You clearly identify findings of acute cholecystitis and your kind of diagnostic workup and thinking is pretty much done. You can kind of put them in the easy button pathway at that point. point. Now here's our next patient. Now remember, patients show up to all kinds of scenarios: urgent cares, clinics, emergency departments. They're admitted in the inpatient service with abdominal pain all the time, and just getting things crossed off your differential can be very helpful. So in this case, this 42-year-old has upper abdominal pain and nausea. You incorporate point-of-care ultrasound with your history and physical. And what do you see here? This is essentially normal, right? This gallbladder looks perfectly clean. There's no stones in here whatsoever. The wall is nice and thin and bright and well defined. The portal vein looks normal. There's no dilated duct running with that portal vein. So this is essentially a normal biliary ultrasound exam. So in this patient, you can kind of move to the other things on your differential diagnosis, cross this one off, and start looking forward, treating other things. And that's, again, how that can help you. It just speeds up the time from history physical to working your differential. And in our next case here, we've got the 37-year-old male who's got right upper quadrant pain. It's been coming on for maybe a few days, maybe a few weeks. It's definitely worse after eating. And what do we see here? So we see a gallbladder that's got a pretty nice, well-defined wall. And maybe if I didn't mention before, the anterior wall is where we best assess the wall. So we look at this anterior wall. It's nice and thin. It's crisp. It's white. It's well-defined. So that's not thickened. It's not inflamed. We don't see any fluid around this. However, we do see multiple stones, kind of more in the body and fundus of this gallbladder. Lots of shadowing coming down from these. Notice how it's smooth, and it gets rough. So those are clear gallstones. We see them here in the transverse view. Nice, smooth, and then it gets rough with these shadows. So these are gallstones. We can see the portal vein over here, and we'd want to get a little better look, but it doesn't look like there's any obvious bile duct dilation in this little quick view. So this is a patient with stones, and their history sounds pretty appropriate for at least symptomatic gallstones. So we just put that together with the rest of the clinical picture. Are they sick? Are they febrile? Is their pain out of control? Are their liver enzymes elevated, their lipase? And we can make a decision on, is this patient sick enough that they need to see surgery pretty quick or in the hospital, or can we get their symptoms under control, their labs look pretty good, and they can go home with an outpatient surgical referral. And again, just showing how incorporating point-of-care ultrasound along with your history and physical can just kind of solve these problems and expedite your thought processes on these patients. So quick summary of the biliary tract, just reminders of how to get good images, have the patients take deep breaths, make sure you examine from the fundus to the neck, and identify all of your landmarks, the portal vein, and the common bile duct. Things you're looking for are stone sludge. Is it tender? Is the wall thickened or irregular? Is it layered? Is there pericholecystic fluid? Incorporating this early as a part of your history and physical exam can just make your differential diagnosis a lot shorter and give you immediate answers when you have positive findings. So with that, we're going to take a little quick look at some hernias. I think this is just a super relevant, high yield thing to be looking at in surgical patients or patients that may be where surgical evaluation is requested. We're going to look at some examples and then we'll go to that case. This is a super subtle one, okay? But what we see in this case, here's the peritoneal lining, and we see as we fan through here, we see something violating it, and then we see kind of loss of that peritoneal lining, and that's basically a little bit of omental fat peeking through. So this is just a fat-containing hernia. In this example, we see it a little more clearly. We identify the peritoneal lining, and then we just see something kind of violating it, pushing through. This is a little bit of omental fat. This is a fat-containing hernia. I don't know exactly where on the body this is, but the patient says something hurts here. Maybe they feel a lump. Maybe you don't feel it because these can be subtle, but you can kind of look where it hurts with ultrasound and quickly say, yes, I see this hernia, and then help you decide what to do with that. Here are some more profound or more obvious examples. In this one, we see an obvious just loop of bowel. This looks like large intestine with haustra, and we can see that. Now, it'd be nice to get a wider view, maybe with a curve, and see the peritoneum and where it pops through. Here's another one. This is a loop of bowel with, looks like there's probably some stool in there. You can see it peristalsing. It's got fluid around it. So this is another, patient says, I have a lump here and it hurts. You can look and see what it looks like. And these are both kind of clear bowel-containing hernias. Now, are they reducible or not? Are they incarcerated? That takes a little more evaluation. And this is that same one we saw earlier. This is very subtle omental fat kind of pushing through. You see the borders of the peritoneum and then omental fat kind of just pushing through that little defect. Now, sometimes the patient points to an area, maybe in their groin or somewhere that hurts, and they say it's swollen and painful, and your first thought might be, well, maybe it's a hernia, or maybe it's an abscess or something like that. And ultrasound can be incredibly helpful in helping you differentiate what is this swollen lesion in their groin or in their abdomen or wherever it might be. In this case, obviously, if you thought it was an abscess, point-of-care ultrasound would change what you want to do with that. You certainly don't want to perform an IND on this, and you're not going to try to reduce this quote-unquote hernia, as what you see here is clearly a pseudoaneurysm. We've got the femoral artery here. We see kind of the classic yin and yang pattern of the blood flowing in and out of this pseudoaneurysm. So to talk just a little bit about integrating this clinically, again, patient says, I've got a swollen lesion, maybe it's painful. History, physical, and point-of-care ultrasound. Hernia, yes or no? Is it some other mass? Is it a lymph node? Is it a vascular abnormality? Is it an abscess? There's lots of other lesions that you may want to look at, and you can, in seconds, usually decide what you're looking at. If it is a hernia and you think it's a candidate to reduce, you can reduce it. Maybe it feels good. Maybe you'd want to double check. You can confirm reduction right there in seconds at the bedside with ultrasound. So in our patient here in this case, they came in, they say, yeah, I've got this inguinal swelling and pain, and you look in the groin and you've got this very clear loop of bowel. We see the neck of this hernia as it kind of hops through right here. You see it popping through the peritoneum, and so we feel it. It doesn't look like it's strangulated, so we think this is a candidate to try to do a bedside reduction. And just even though it feels good, it's always nice to get another look post-reduction and have extra visual and imaging confirmation that the hernia is no longer there. It's been successfully reduced. And this patient maybe can go home within a 10-minute visit. So that's just the power of kind of evaluating these swollen mass lesions in patients that are undifferentiated with ultrasound. So quick little summary, just as we've said before, you get the biggest benefit when you incorporate point-of-care ultrasound just as an additional component to your history and physical. You can get immediate bedside answers, sometimes find and confirm the diagnosis in seconds. Or if you find something a negative or a normal study, that's going to change your differential and make your differential diagnosis shorter and make the rest of your workup more efficient, and can just be a really powerful tool that can help you in these patients who have these different symptoms of abdominal pain or swollen areas. So I hope that's helpful. I think that's everything I have for you for now, and I'll see you off in the next one.